Cross River State domesticated the task shifting policy in 2016 for one stated reason, and it is worth hearing it plainly. In the rural areas, there were few or no better skilled health workers available. That was the whole rationale, not a preference, not an efficiency argument, a description of a place, which means the setting was never incidental to that innovation. The setting was the reason the innovation existed at all. So here is the question recommendation 6 puts to every one of us, and it is uncomfortable in exactly the right way. If your intervention exists because of a hard setting, where did you test it? Because in my experience, most pilots are quietly run somewhere else. Not dishonestly, just somewhere the pilot can succeed. Recommendation 6 of BWEIM says, test the innovation in the variety of sociocultural and institutional settings where it will be scaled up. The guide is specific about what that means in practice. If your objective is to improve access for the underserved, then test where the underserved actually live. If the goal is national implementation and the country is culturally diverse, and Nigeria certainly is, then pilot across as many diverse regions as you can manage. If the innovation will eventually run through public facilities or private ones or NGO systems, then conduct the project inside the institutions that are expected to carry it. And this one gets missed constantly. An intervention meant for community level delivery has to be tested at community level, not only at the district health center, where the supervision is better and the equipment works. Why does this go wrong so reliably? Not through bad faith, through gravity. A pilot has a timeline, a budget, and a results framework, and every one of those pulls toward accessible sites. The facility near the state capital, on a good road, with a full staff complement and a cooperative officer in charge. The one where your team can supervise weekly without losing a day to travel. And that choice is entirely rational for the pilot. It is also the choice that produces evidence about a setting you will never scale into. A pilot run on easy ground answers a question nobody asked, which is whether the innovation works under favorable conditions. The question that matters is whether it works in the places that made the innovation necessary. And here is the part that costs the most, because it arrives disguised as something else entirely. When the results do not replicate at scale, almost nobody in the room says our evidence came from the wrong places. They say the implementation was weak. They say the health workers need more motivation. They say context, which in our sector has quietly become the word we reach for when we do not want to name a design decision. So the response is another round of capacity building, another supervision push, another training. And none of it works because the problem was never implementation quality. The problem is that the evidence was generated in a place the innovation was never going to have to survive. A pilot on easy ground does not simply produce a weak result. It produces a confident result, and a confident result sends an entire program looking in the wrong direction for years. When the guide says sociocultural variety, it is not a diversity checkbox. It is a warning that the same intervention meets different weather in different places. Community acceptance differs, gender norms differ, and the Cross River record is explicit that husbands were perceived as a significant barrier to accessing family planning services. Distance and terrain differ. Which language the counseling happens in differs. An implant service that works where the community already trusts the facility will behave differently where it does not. And neither result is wrong. There are results about different places. If you test in one and scale into the other, you have not scaled your evidence. You have scaled your hope. Now, the half of recommendation number 6 that almost nobody plans for. Institutional settings vary as much as social ones, and they vary in ways that decide whether your innovation is even permitted to operate. The cross-river lessons learned are honest about this. Stakeholders held genuinely divided views on the task shifting policy. Some embraced it as a necessary stopgap, given the workforce reality. Others opposed it outright, on quality of care grounds. Those are not two opinions about one setting. They are two different institutional environments, and an innovation that flows easily through the first will meet a professional association, a regulatory question, and a slow approval in the second. Testing only where the leadership already agrees with you tells you how your innovation performs among allies. Scale does not happen among allies. Scale happens everywhere, including the places that were never convinced. So what did the cross-river scale-up do with this? It went wide, and it went wide deliberately. The strategy the resource team implemented between 2017 and 2019 reached all 18 local government areas of the state, not 3 demonstration LGAs, all 18, that produced 152 trained health workers across 76 facilities, and it produced them across the whole spread of the state, urban and rural, near and far, easy and hard. And that is what makes those numbers mean something. If 152 CHUs had been trained in the 4 most accessible LGAs, the figure would be identical, and the evidence would be worth a fraction as much, because the state would still not know whether the model survives outside comfortable ground. Coverage across variety is not a logistics achievement. It is an evidence achievement. There is a sharper version of this test that takes 1 minute to run, and I recommend it on every design you review. Write down the exact type of service delivery point where this innovation will be delivered at full scale. Not the level, the actual point. A primary health center with 1 GW and intermittent power. A community outreach session under a tree. A private chemist shop. Then write down where your pilot is running. If those 2 lists do not match, you do not have a pilot problem in the future. You have an evidence problem right now. Because whatever you learn will be true of the place you tested. And the place you tested is not the place you intend to scale into. The honest objection? Testing across that much variety is expensive, slow, and beyond our budget. True, and the guide concedes it. Notice the exact wording. It asks you to conduct the project across the variety of settings where scaling will take place, to the extent possible. Representative, not exhaustive, which turns this into a design question rather than a budget question. If you can afford 4 sites, do not choose 4 convenient ones. Choose 4 that differ on the dimensions most likely to break you. The hardest terrain, the most skeptical institution, the thinnest staffing, the weakest existing service. 4 well-chosen sites will teach you more than 12 comfortable ones, and they will cost you less than discovering the same lesson in year 2 of a national rollout. So recommendation 6 asks a simple question with an uncomfortable answer. Are the settings you are testing in the settings you intend to scale into, socially, culturally, and institutionally? Test where the underserved live. Test at the delivery point, not the referral center. Test where the leadership is unconvinced, not only where it is friendly. And when budget forces you to choose, choose for difference rather than for convenience. In the next episode, recommendation on 7, and it is the one I would put at the center of this entire series, testing the innovation under the routine operating conditions and the real resource constraints of the health system. Subscribe so you do not miss it, and tell me in the comments, in the last pilot you were part of, how different were the sites you tested in from the places the results were meant to travel to?